afternoon, everyone, or buonasera, or good morning, or good evening, based on where you are in the world. So we are keeping on our liver imaging online series. We are continuing them. We thank all the speakers who have participated in the first round. We have esteemed speakers. They were all received excellent feedback. We have two speakers overlapping for the first and second round of lectures. Dr. Lala, we're going to listen to her. I think everyone is expecting and waiting for her lecture on Friday. And Dr. Bashir. So today we're starting the second round of series, and with the second round of series, we have great lineup, and I'm really excited, in particular with our guests from different institutions. So we have our different specialties, because I believe that radiologists cannot be good radiologists without understanding in depth some of what other physicians need from us. So in particular here we have Dr. Armin. He's not from different specialties, radiologist, but he's interventional radiologist, and he's going to give two lectures, one about all procedures, interventional procedures in the liver, and the second one in particular about Y90, which is his area of expertise. Also, Dr. Abhinav Humar, and he's from Pittsburgh. He is a very famous, world-renowned liver transplant surgeon, and he's going to join us also on Wednesday, May 27th. And we have a very exciting lecture to end our series with Dr. Neil Thies, and he's a very nice and kind man. He's a pathologist and very accomplished pathologist. And this one, I'm very excited for this lecture in particular because he's going to sort of collaborate with Dr. Klutz Serlin in RAD pathological correlation of the process of hepatocarcinogenesis. So this is again going to be a very exciting lectures, and we have also lots of other lectures and great speakers, starting by Dr. Bashir today, and because of the successions, we're ending with Mustafa Bashir, right? The last name is Bashir. So tomorrow will be Bashir Taouli. And I didn't find anyone with the first name of Taouli to start the third day. Okay, another one joke that is not understandable, but that's fine. As I said, I'm giving these jokes to entertain myself. So without further ado, I'd like to introduce today's speakers, Dr. Mustafa Bashir. Mustafa is a great friend and colleague, very nice, down-to-earth colleague and a friend. He is Associate Professor of Radiology and Medicine and Director of MR in Duke University. And usually when I start introducing my colleagues, I insist on giving me the number of publications to put it in the introduction. And he told me that he sent me this. He is the author of more than 5 peer-review publications. 5 peer-review publications. That was yesterday. I looked up, and the PubMed today it was 155. So I must have been very busy since yesterday publishing the 150 publications. He is also director of the Center of Advanced Magnetic Resonance Development in Duke, and he's also the chair of the research working group of LI-RADS. Dr. Bashir is very unique for his in-depth understanding of MRI, of imaging in general and MRI in particular, and liver imaging even as a more area of expertise. And he led many national committees. He is the associate editor of Journal of Magnetic Resonance Imaging. He is, committee chair and International Society of Magnetic Resonance Imaging. So if I were to continue talking about Bashir, it will take the next hour to just talk about him and introduce him. So I would like him to start his talk about imaging of liver, iron deposition, and steatosis. One last thing about Dr. Bashir is, he was supposed to be speaking Arabic, but the only word he knows about Arabic is Assalamu alaikum, sabah al khair. That's it. and so it's like my kids, that's why I'm very attached to him. That's why I like him so much. That's why I see him like my kids, although he's not much young as my kids. So, Dr. Bashir.
Thank you, Khaled. That's a very kind and generous introduction. I want to start by congratulating Khaled and Bob and all of the speakers for the fantastic lectures up to this point. And I'm looking forward to all of the great lectures to come afterward in the next few weeks. Today, we're going to take a little bit of a sidestep from the topic of liver cancer. Most of the lectures up to this point have been focused on liver cancer. And today we're going to talk about another topic in the liver, which is fat and iron quantification. You saw my disclosures there. So I'm going to frame this talk first by talking a little bit about the motivation for quantifying iron and fat in general, and the roles that these might play in taking care of patients. Then I'm going to talk in more detail about how we do these, and then go into the why, not from a big picture standpoint, but practically, why would you do iron quantification? Why would you do fat quantification in your practice? Because I think one of the very interesting things about these is that the original motivation for developing these methods and then how they're actually used are not necessarily the same. So let's start with why anyone was originally even interested in quantifying iron or quantifying fat. And to start with iron, liver iron overload is a recognized derangement of liver metabolism, where iron particles are directly deposited within the liver, and due to oxidative stress, these cause chronic inflammation. They can lead to hepatic fibrosis and cirrhosis. And this occurs not just in the liver, but also in the heart as well as other organs. It's very well shown that that reducing organ iron levels can reduce the toxicity due to iron. So there are treatment strategies that involve iron chelation and removing iron from mainly from the bloodstream, which allows iron to then equilibrate out of organs and into the bloodstream, and reduce the iron burden within the organs. The challenge is on the diagnostic side, where there are really no good non-imaging techniques for quantifying liver iron. There's the best one outside of imaging is the ferritin blood test, and it's a fairly non-specific test. Ferritin goes up anytime there's acute inflammation, and so an imaging method was desirable and has a strong role, partly because of the lack of suitable alternatives. Now, the story with liver fat is a little bit different. We know that liver fat deposition is very very common, and most people with fatty liver have asymptomatic fatty liver. And when you think about chronic liver disease, until recently, viral hepatitis and alcohol-induced chronic liver disease were the main drivers of cirrhosis and liver cancer. But with worsening obesity and metabolic syndrome throughout the world, this has really changed, where non-alcoholic fatty liver disease has become more common. Non-alcoholic steatohepatitis, which is its more aggressive cousin that leads to cirrhosis, has become much more common. And there are now medical treatments for hepatitis C, where the prevalence of hepatitis C is actually going down. And so in some parts of the world, this has happened already, but overall in the world, we're going to see non-alcoholic fatty liver disease and NASH take over as the most common and most important causes of chronic liver disease that lead patients to get cirrhosis, liver cancer, and require transplant. Fatty liver disease is the hepatic manifestation of the metabolic syndrome. It's closely associated with diabetes and obesity, and so on. And currently, there are really no medical treatments for an alcoholic fatty liver disease and NASH. And so the drug industry is very interested in this, and there are tens of millions and hundreds of millions of dollars being spent on clinical trials trying to come up with treatments for NAFLD and NASH. And so things like making a diagnosis and assessing a treatment response are going to become more and more important as treatments become available. So this is kind of the big picture scenario for fatty liver disease and why we should care about it and trying to quantify liver fat. Now let's go a little bit into some of the techniques for quantifying these. For iron quantification by MRI, there are historically 3 methods. The first is the method that was published by Dr. Gandon, who is from France, and this was kind of the traditional way of doing liver iron quantification. It involved acquiring 5 sequences, a combination of spin echo and gradient echo, and doing signal intensity ratio measurements to approximate the amount of liver iron present. And if you look at the web page where this method was described, and you could take your numbers and put them into the web page to get liver iron concentration, you'll now find this warning because the web page is being taken down. The folks who maintain it have decided that this is really not the method of choice anymore, that we should be using one of the other methods. And what are those other methods? The other 2 methods are based on either R2 or R2 star relaxometry. And these relaxometry methods use this underlying concept. If you do an MRI experiment, if you do an excitation and then wait to see what happens to the signal intensity, in general, the signal intensity will decay over time, and it will do it according to an exponential curve. And you can measure that exponential curve, and the decay constant for that curve will give you the R2 value or the R2 star value, depending on whether you do a spin echo or a gradient echo sequence. And so you can acquire multiple echoes at different echo times using either a spin echo or a gradient echo sequence. And on a pixel by pixel basis, you can plot the signal intensity for each pixel and then do this calculation to get the decay constant for that pixel, and that corresponds with the liver iron concentration. So that in a nutshell is how it works. For R2, there was a lot of work done in the early 2000s correlating R2 values with biopsy derived liver iron concentrations, and so we have calibration curves that directly relate the R2 value that's measured at MRI against the biopsied liver iron concentration. So you do your measurement, you calculate R2, and then you go along this curve to figure out what your liver iron concentration is going to be. This is available as an FDA-approved send-out test. It's always nice when tests are FDA approved, and this is one of them. In terms of the practicality, this is a multi-echo spin echo sequence, and it takes a bit of time. It takes a good 7 to 10 minutes to run this sequence. It's done free breathing, and it's extensively evaluated in kids during free breathing, and it's a nice robust test. So that's one way to do iron quantification. The downside is that there's an additional charge. It's a send-out test, so you have to figure out the data transfer, and it does take a good 10 minutes to do. That's the R2 side of things. On the R2 star side of things, if you remember back from physics, R2 star can be measured using a gradient echo technique, and the technique is essentially the same, where you get a multi-echo acquisition. You derive the decay curves for each voxel and calculate the decay constant. But in this case, because you used a gradient echo sequence, you get an R2 star value rather than R2 value. There are well-validated calibration curves for R2 star, which again, you calculate an R2 star and you go to the curve and you get your liver iron concentration based on the R2 star. The big advantages of the R2 star method are that they're much quicker. You can do these in a single breath hold and get a single slice or multiple slices. And you can calculate these in-house. You can calculate the R2 star value using vendor-supplied post-processing packages, and then use the calibration curve yourself, so it's not necessary to send out the data. R2 star is a little bit more complicated in that if there's coexisting fatty liver, you may need to do a correction for that. I'm not going to go into detail with that, but that can complicate things a little bit. It's also not quite as robust to motion. So if you have a patient who has difficulty holding their breath, the data quality may not be as good as it is for an R2 measurement. One thing that's important to know about these techniques is that echo spacing and some of the other parameters in your MR sequence are important. So in an ideal curve, you'd have something that looks like this, and when you do all of your echoes, you sample nicely along the curve and you can figure out what the curvature is. But there are some patients who have very little liver iron, and if you sample the echoes too close together, you may see a relatively flat curve. And so this number may not be very accurate. There are also patients with very large amounts of liver iron, and in those cases, the susceptibility effect is very, very strong. And so the curve bottoms out very quickly, and some of your data points will be collected that are just noise. And so this can be a tricky thing. With R2 based techniques, generally these variations in values are not that big. So if you use the standard protocol, sampling with echo times from 3 to 18 milliseconds, it will cover pretty much all of your scenarios. With R2 star, these changes in curves and signal decay can be much larger. And so you'll run into some patients like this, you'll run into some patients like that. So some institutions will set up multiple scans in their protocol where they have longer echo spacing and shorter echo spacing so that they cover all possible scenarios. Okay, so we're mostly done with the technical jargon. Let's talk about some of the practicalities. So fat quantification. Sorry, I got ahead of myself. We're done with the technical jargon for iron quantification. Let's talk about the technical side of fat quantification. So historically, spectroscopy was the gold standard way of doing this. Spectroscopy is a technique that requires a pretty high skill level among your technologists, and it's a little bit difficult to do quality control on. So a bunch of alternative techniques have been proposed. And there are issues with many of these techniques, and what the field has gone toward is a chemical shift encoded manner of doing fat quantification. And so this involves a gradient echo sequence, and this is the curve that describes what happens with your signal over time when you do one of these gradient echo sequences when there is fat present. So you'll notice that this is similar to the iron decay curve in that there is generally a decay over time of signal. The signal gets less and less, but it's different in that you'll see this undulation, and this undulation is related to water and fat protons going in and out of phase. If you sample along this decay curve at the right times, you can catch water and fat when they're maximally out of phase and maximally in phase. This is very similar to the dual echo technique that we use in routine clinical imaging. And if you sample enough data points, you can actually calculate the characteristics of this curve. And one of those characteristics is the amount of fat relative to the amount of water, the so-called proton density fat fraction, or PDFF. The equation that describes this curve is actually quite complicated, and it's not one that we want to think about in too much detail. The important part to remember is that there are a lot of factors that go into this equation, and so we have to do corrections for a variety of different issues. One of them is signal decay. One of them is the complexity of the fat spectrum. And so if you do all of these corrections appropriately, then you'll get an accurate PDFF measurement with your sequence and your reconstruction. Now, something to know if you're going to do this in your practice is that the vendors provide reconstruction methods that should give you accurate PDFFs, but it's still possible to make mistakes with the sequence if you change them and don't set them up appropriately. So the parameters like the TR and the TEs and the flip angle, these all matter. And this is I'm going to show one brief graphical example of how you can get an incorrect PDFF measurement with these by changing the parameters. So this is a nice case where you've set your echo times to measure the bottom and the top of the undulations of the curve, and this will accurately tell you how much of this change is related to the interaction between fat and water protons. But if you change your echo times, you can set them so that you don't maximally measure these undulations, And if you do the sequence in this way, you'll get a falsely lower PDFF value, even though you're doing the same sort of measurement and using the same image reconstruction. So if you're going to use the vendor supplied techniques, you want to be very careful if you're going to alter them to make sure that you're confident in how you're altering them and that you don't introduce some sort of an error. And assuming everything goes well, you can get a very nice looking PDFF map that accurately presents the amount of fat in the liver. So now, technical stuff aside, let's go back to motivation. And I talked about, in general, what the motivations for measuring liver iron and fat are, but let's talk about how they're actually used in practice. So there's a direct and well-described relationship between the amount of iron in the liver and liver toxicity. We consider up to 1.8 grams of iron to be at the upper limit of normal, and we know that there are significant risks of hepatotoxicity when tissue iron gets above 5 grams of iron per milligram of tissue. Not only are these thresholds important in terms of liver toxicity, but in general, liver toxicity comes before cardiac toxicity. So knowing what the liver iron concentration is can tell us whether or not we need to also assess cardiac iron and cardiac function to see whether or not the patient may be starting to have a cardiomyopathy related to liver iron. So liver iron concentration has a nice role in the diagnosis of abnormal liver iron overload, and it can also be used to assess response to treatment, whether that's medication or phlebotomy. We can do serial measurements to see whether the liver iron is going up or down or staying the same based on the treatments. So this is a really nice case that we had some years ago. This was a 58-year-old woman who presented with a bunch of nonspecific constitutional symptoms, had a medical workup that was unrevealing, and ended up having a liver ultrasound that showed liver masses. So she went to MRI, and the MRI showed that these masses were hemangiomas, but surprisingly, they also found really severe liver iron overload in this patient. They did a genetic test and found that she was homozygous for hemochromatosis. And this was back in the days when we were still validating liver iron measurements with MRI. And so they did a biopsy and found really severe iron deposition in her liver, confirming not only that she had hemochromatosis, but she had severe iron deposition. So she went on to phlebotomy and her symptoms resolved. Her nonspecific lab abnormalities got better. And these are MRIs. This was the one at the time of diagnosis. This is an in-phase T1 weighted image. And then here's the in-phase T1 weighted image after she'd completed her course of phlebotomy. And she went from an estimated liver iron concentration of 11.5 milligrams per gram to 0.9 milligrams per gram. So from severely abnormal down to the normal range. So we were able to show that her treatment was very effective. So again, liver iron quantification using MRI has a nice role in the diagnosis of liver iron overload, as well as monitoring treatment effectiveness and the need for cardiac assessments. One of the things that's tricky in these patients is that they don't all respond to treatments in a similar way. Many of these patients, especially in our practice where we have a large sickle cell population, many of them are kids, so it can be challenging to get them to take oral medications every day. Their chelation therapy may be not strong enough or strong enough, and it's hard to know how effective the treatment is unless you can directly measure what's happening in the liver. And so in our practice, these folks will get follow-ups every 12 to 18 months. And they may change their treatment algorithm if they're not responding to the current treatment therapy. And it can be similar as changing them from a daily medication to a weekly medication, because weekly, for whatever reason, is easier for this patient. Daily may be easier for that patient. You can choose the therapy that is that clearly has the greatest benefit in that particular patient. So now switching to liver fat quantification. Here the story is a little bit more muddy. We have this motivation that liver fat is a major cause of morbidity and is becoming the main cause of chronic liver disease, and that it's part of the metabolic syndrome, which is becoming more common and more severe in patients in general. But the story with liver fat is not as clear-cut as it is with liver iron. With liver iron, we know that worse liver iron is bad for you. It means your disease is worse. It's going to be more aggressive. With liver fat, that's not the whole story. The diagnosis of non-alcoholic steatohepatitis, which is the fatty liver disease that actually leads to cirrhosis, has other elements besides simply deposition of liver fat. There's inflammation, there are pathologic findings other than fat and inflammation, and it's very difficult to measure these directly. When we are only able to measure liver fat, it turns out that liver fat is not that well correlated with the other manifestations of NASH. So this chart shows on the y-axis a point system called the NASH activity score. This is a biopsy-based point system that includes liver fat and some of the other pathologic findings of NASH. And more or less, this is not an exact science, but more or less you can say that people with a score above 5 or above, you generally will have NASH, and those below 5 generally will not have NASH. And if you plot this against the proton density fat fraction, you can see that even though there's a general trend to having higher proton density fat fraction in patients with NASH, there are a lot of patients with NASH that have lower PDFF values and a lot of patients without NASH that have higher PDFF values. And so there's no good place to draw a threshold of PDFF value to say people above this have NASH and people below it don't have NASH. It just doesn't work that way. So for the diagnosis of NASH, PDFF or liver fat quantification doesn't work all that well. How about predicting downstream outcomes? There are now a couple of really long-term natural history studies. These went for about 15 to 20 years, where they biopsied patients with NASH and followed them for 15 or 20 years to see what features at the time of original biopsy actually predicted their outcomes in terms of developing worsening hepatic fibrosis, cirrhosis, and other causes of morbidity and even mortality. And what both of these papers found were that at baseline, liver fibrosis was the only feature that was associated with long-term outcomes in patients with NASH. So liver fibrosis is very important, and hepatic steatosis doesn't predict long-term outcomes very well. So as I mentioned before, making the case for liver fat quantification is a little bit more difficult. We don't make a confident diagnosis of NASH based on liver fat quantification, and we can't prognosticate what is going to happen to these patients in terms of their liver-related morbidity and mortality based on their PDFF. So what is the potential role for liver fat quantification? Well, it turns out that following liver fat in patients known to have NASH, that may actually have some value. So if you, as I mentioned before, there are currently no approved treatments for NASH in the United States. Worldwide, there is one approved treatment in India, but in most countries there is no approved treatment. If we look in the research data in the clinical trials that are currently going on for the treatment of NASH, we find a lot of tables like this one for the drugs that have been successful, and they show that in treated patients, when they have a reduction of their overall NASH activity score, and when they improve their fibrosis, very often their steatosis also improves. We don't know whether one of these is cause and effect. Many people think that this is all related to the metabolic syndrome underneath improving, and that the improvement in fibrosis, the improvement in the NASH activity score, and the improvement in the steatosis are all effects. None of them is a cause. But regardless, there is the potential to monitor people for improvement by monitoring their steatosis. The question is, why wouldn't you monitor their fibrosis directly or monitor something else directly? And that's because the rest of these markers all require biopsy. You can try to monitor fibrosis with MR elastography or an ultrasound-based elastography technique, but so far this has not been as successful for predicting the histologic outcomes as monitoring steatosis has been. So this might potentially be a place where liver fat quantification can have a role. Now, how much liver fat do you have to improve to say that things are getting better? Well, there's a trial from about 5 years ago called the MOZART Trial that showed that histologic responders in terms of steatosis tended to have higher liver fat improvement as measured by PDFF, and that number was somewhere between 4 and 5% reduction in PDFF. In relative terms, this correlates to about a 30% relative reduction in PDFF. So if you have a patient who starts with a PDFF of 10 and they go into treatment, and after treatment their PDFF is less than 7, then you can say, well, this person has a high likelihood of being a histologic responder. More recently, this study was published earlier this year, and this is one where they examined not just histologic improvement in fat, but PDFF measurements as predictors of improvement in either NASH or improvement in fibrosis or both. And they found that PDFF was a pretty strong predictor of improvements in histology in NASH and fibrosis at biopsy. So this is another supportive study that suggests that we can use PDFF measurements to predict who is having a response and who's not. There are now some trials underway, and a couple of these have results that have been announced in press releases and abstracts, but not in papers yet, that have shown that early measurements of PDFF can predict downstream treatment response. And so it may be that we end up using PDFF measurements to decide who is responding to therapy, so we can take patients off of therapy who are not responding. When these drugs come out, there will probably be long treatment courses of 1 to 1.5 to 2 years. And if we're able to show using MRI within the first 6 to 12 weeks that a patient is responding or not responding, this will be very useful, because in the non-responders, you can take them off that medication and try something different and spare the time and the cost of 1 to 2 years of treatment. So this is all where PDFF might be going in the future. Here, now, and today, we're not doing those measurements because those drugs are not approved and not released yet. So I want to wrap up here, and hopefully I've left lots of time for discussion and questions. I want to summarize by saying that I've talked a little bit about the potential role of measuring liver fat and iron using MRI and how we do it. And then I've tried to describe a bit how we actually are doing this in practice now. The case for liver iron measurement is pretty clear cut. The case for liver fat measurement here, now, and today is not very clear cut, but there may be some applications coming down the road. And with that, I want to thank you all for your attention and hand it back to Khaled. Thank you.
Mustafa, that was great lecture. Thank you very, very much. Man, I really consider Dr. Bashir one of the few scientist physicians. Not every physician is scientist, but Mustafa is a real scientist, and he's having in-depth understanding of the things that he investigate, and I consider him the best in this topic. And we in liver group, we all know how good he is in this particular topic, given his expertise and long research with the quantification of iron and fat and imaging of the diffuse liver diseases. With that, I would actually conclude the first part of our session today. So thank you very much, Mustafa, and thank you everyone for attending.